say we want people to age in place, but we don't actually pay for what makes that possible. My hot take this week: independence at home is often dependent on what someone can afford out of pocket to remain in their home. We've talked about home modifications and aging in place, and a big piece of that is safety equipment in the home. Grab bars, shower chairs, hospital beds, ramps, adaptive equipment. I've worked in acute care for almost a decade, and one of the biggest pain points and sometimes barriers to discharging patients home safely after a surgery, injury, or sickness is the added cost of durable medical equipment, assistive devices, and adaptive equipment. We fund crisis care, we don't fund prevention. And then we're surprised when people fall or end up coming back into the hospital over and over again. This week, we're asking questions. Why are the very tools meant to make someone's home safer and more functional so often the biggest barrier to a safe discharge? What does insurance actually cover when it comes to DME? And where do families most often get blindsided? Why doesn't insurance cover some of the equipment? Welcome to the Aging Together podcast. I'm your host, Dr. Pooja Ashok Patel, a double board certified occupational therapist and gerontologist with additional certifications in dementia and fall prevention. This season, we are unfiltered. In this podcast, I interview guests who are experts in their fields or caregivers who are sharing their lived experiences. Let's meet today's guest. Joining me today to help break down what's covered, what's not, and how families can access equipment they can't always afford, I'm joined by Erica Sell, founder of Harmony Home Medical. Erica, welcome to the show.
Hi, Pooja. Thank you for having me. Excited to be here.
Absolutely. I'm sure working in this industry, you have your own hot take surrounding this topic. So go ahead and share one.
Well, I think that the powers that be, the payer sources and the legislation, the people who make that legislation, have it backwards. Because if we had more coverage and higher allowables in that coverage for medical equipment at home, then I think the overall cost of care to the healthcare system would come down dramatically. But unfortunately, that's not the world that we're living in, and it is an industry with very little lobbying and very little Capitol Hill representation. So over the last decade and a half, it's really gotten hacked as far as what they pay for certain items and then what items are covered. It's become more and more challenging, unfortunately. And maybe moving forward with telehealth and our little blip with COVID that we had that showed us medicine at home is possible and sometimes better outcomes, we may see a turn down the road. But as it stands today, people need to know what's covered, and it's less than they often think.
Yeah, strong on the point about how investing in this stuff preventatively would benefit the downstream costs of healthcare. Right. I think people don't understand that that's the whole point of prevention, is that there's not only is it better for the population and individuals, but it's better for our healthcare system and our healthcare costs. And I don't think enough people realize that.
Yeah, especially the people who make the rules around it. They when they made all these cuts, it was kind of like throwing the baby out with the bathwater. They had a few bad actors and fraud and not enough people educating the healthcare industry at large about how much prevention medical equipment can provide and how much cost savings that can be. When you give someone an air mattress before they have a pressure sore, that on average saves $70,000. Those sort of things that they just don't realize. So we are here to educate the client and the end user, because regardless of payer, who wants to even go through a fall or a pressure sore or an outcome that could have been prevented with the right piece of equipment?
Exactly. Number one place where falls occur are in people's bathrooms, and just the bathroom equipment itself is not covered in most cases. And the cost of a fall leading to a hospitalization, God forbid there's an injury with that fall. Now we're looking at hundreds of thousands of dollars in hospitalization costs and rehab costs before they end up returning home, potentially still with more therapy needs and caregiver needs. And so 100% on that. I think people just really don't understand outside of healthcare how important that is. I think let's start at the basics. Let's identify just, I mentioned like ramps, shower chairs, grab bars, all that kind of stuff. You mentioned air mattresses for pressure injury prevention. What are just some general other like equipment that people might not think of that could be potentially preventative or helpful in the home?
Well, there's a lot of bathing equipment that people don't know about, and also some higher end or specialty beds, and the lift chair. I think a lot of people know about the lift chair, but a lift chair with some of the higher functionality, dual motor. They now have lift chairs with Trendelenburg, which is a kind of a tilt that gets your heels way over your heart. So there is a lot of equipment not covered. Probably the majority of equipment is not covered. So for starters, I'll kind of do the pyramid of coverage. So the insurance, and we're going to talk primarily about Medicare because that is the payer that a lot of our clients and listeners have, but then also that a lot of insurances make their guidelines based off of. So it's the core payer who's deciding a lot of things. So with Medicare, you started a cane, and then a basic walker, walker with seat and handbrakes, a standard wheelchair, lightweight wheelchairs only for certain diagnoses, power chairs, and bed and a commode and a patient lift. Those are pretty much all the things covered, and an air mattress. But the thing is how are they covered, when are they covered, and how much do they pay for that coverage? And also when can you get that coverage? So it's kind of a pyramid of need. Once you move from a cane to a walker, you can't go back to a cane. Once you move from a walker to a wheelchair, you can't go back to a walker. So they're going to cover this item once. They're going to cover it once every 5 years. And if you go get a power chair, you're not going to be able to get a lightweight wheelchair in the future. So you can't get authorized for things, that you don't necessarily need, or that you might want both. You need to weigh the options of which one is more costly, or time your prescribing for those. But so it sounds like a lot of things are covered there. However, they're only covering a power chair, for example, and they barely ever cover scooters anymore because they're considered for secondary activities. The power chair is really the one that can get through the house. But the criteria is only if you can't walk or roll with an optimally configured wheelchair 50 feet or less in your home. So that means basically if you can't walk or roll to your bathroom, from your bedroom to your kitchen, those small spaces, it means it's not covered. If you can use a walker to get around your house, but you really need a scooter or a power chair to go do activities in the community, which is 80% of the people we see come into the store are people who want to use a scooter for an outing or a power chair for an outing to live their lives more fully, to continue to be able to do things they love and the stuff that keeps them engaged. But that's not covered. And then with a bed, we have a lot of people come in, they want a bed, but they want it to be able to get out of bed easier. Well, only a semi-electric bed is covered. So that means the head and foot move, but the height up and down you have to do with a hand crank. And so those are only covered when you cannot change position in bed and pillows have been tried. So you can't really be able to move and roll. You have to be a very high need or high care case. So some of the more common items that people want to just improve their quality of life and prevent a fall and have better care outcomes, they're not covered until they're just at the threshold of even being able to leave their home or leave their bed. So that's something that catch people off guard. And then the weight and the style and quality. They pay very low for each of these categories. So the product provided in that category are very basic and often the heaviest that are available. So that's another thing that people are surprised by. And sometimes, I think it's advantageous just to buy what you want and use the self-claim form. So you get what Medicare does pay, say $90 for that walker with a handbrake and seat, and get the $250 one that's light that you can put in your car that fits you, and have them pay you back what they do pay, but don't sell yourself short to carry around the steel one that's really heavy just because that's all that Medicare covers. So those are some of the tiers of what they cover and some of the caveats about it. But in that bathroom, there's no coverage for a toilet riser, a transfer bench, a shower chair. They cover a 3-in-1 commode when you are bedbound, when you have a care room set up. They'll cover the commode to do bedside. They call it a 3-in-1 because they expect you to go put it into the shower, put it over your toilet, and use it bedside. So, and that's the piece of equipment covered. But bathrooms are where we need to make sure we're covering ourselves as early as possible with grab bars, benches. There's some pretty cool transfer shower equipment that people aren't aware of that you can set up so your bathroom can kind of act almost like you have a roll-in shower, but you didn't do the construction. And none of those items are ever covered except by Medi-Cal and sometimes the VA direct, not TRICARE, but directly from the VA.
Yeah, so for California, the Medi-Cal probably covers. I will say, like for many states, the state Medicaid programs will cover some of that equipment if it's medically necessary. We're the ones writing those letters of medical necessity oftentimes, and I think it's really nice to hear that some of the things that I understood about equipment is what you know to be true too. Because in acute care, a lot of times we'll just hear from social work like, oh, that's not covered. Oh, we can cover this, but they have to meet X, Y, and Z. And I think a lot of times we don't always know all the nuance to that just because, you know, we're making recommendations, but we're not doing the equipment part of it. We're just making the recommendations. And so it is nice to understand how it actually works and what those requirements are. One of the things that always irks me so much is a lot of this equipment that has all these like kind of say like random requirements that someone put together is that they don't factor in the people who live alone and they don't factor in the health and wellness of the caregiver. Because when we're talking about those adjustable beds, right, like they're saying that the person needs to be completely bedbound in order to be able to qualify for a bed like that. Well, even if the person didn't fully qualify, it would decrease the burden on the caregiver to be able to help them out of bed, even if they didn't need max total assist, even if they only need a little bit of assist, it would still decrease that burden of care on the caregiver. And I think there's just not enough stipulations around that for caregiver burden and how preventing injury for the caregivers too, because we do a lot of that education and training too.
Yeah, the system does not take into that cost savings either of family caregivers caregiving at home versus a skilled care setting and how to support those people doing that work so they can stay healthy and stay well. That height adjustable bed would be amazing for them. And then other transfer solutions. The only covered transfer aid for Max Assist is the manual Hoyer lift. And it's so daunting for so many caregivers to not only do the hand crank part, but then to push it on the carpet or whatever it may be, to do the rolling of the client to the sling, where there's other lifts between the powered lifts, ceiling lifts, sit to stand, which is just a different position the client gets to be in. It's so much less work when you put them into the chair, and it's also a lot less scary for both parties. Those are all better ways to perform that aren't covered at all ever.
Yeah.
And so it's missing the mark of how we can keep people healthy and safe at home and giving value to that caregiver cost, caregiver burden, so to speak, that the system isn't bearing.
I'm smiling because the sit to stand lifts are our biggest point of contention in acute care if we're trying to send somebody home instead of a nursing home, if they don't qualify for rehab, or if this is their baseline and the caregiver is just the family's looking for like better options for transferring. And it's like, we want to preserve the strength and the skills that they have. So a sit to stand is good because they can still use their legs and still use those muscles until they can no longer do that. Instead, insurance is only going to cover the Hoyer lift or the total lift machine, which will then completely deteriorate the person's remaining muscles and become increasingly dependent, which then leads to more risks for pressure injuries and UTIs and pneumonia and all the other things that will just lead to more hospitalizations and more costs.
Yeah, and they're so cumbersome to use that most caregivers are going to skip it and try to do it themselves up until they absolutely can't or until they hurt themselves. And the sit to stand is one of my favorite products because a lot of people don't know about it. So when you get to introduce it, especially to couples caring for each other, it reopens the door of possibility to be able to do transfers safely and independently at home. The Hoyer lift, the body position coming into the chair, it's very hammocked. And so getting the bottom to the back of the seat, it's so hard. Pushing on the knee, I push on the knee to try to push the person's bottom back in the chair, and it's hard to do alone. So that sit to stand eliminates that, and it takes a bunch of fear out, and it's so much better. So sharing it with people and then just giving them the opportunity to find a way, because it's unfortunately it's not covered. But doing a rental, we rent a lot of equipment. Doing a rent to own, doing a used equipment purchase And then sometimes there's grant programs, but most people fall in the middle. Most people, most of America falls in that middle class on Medicare, not necessarily on Medicaid, doesn't qualify for a diagnosis specific grant program. There's just not a lot of support. So they need to be resourceful, and find ways. And so I think the rental, the used equipment, financing, like utilizing, we have a program with the Wells Fargo card, you 0% interest for 18 months. Apply for that and make it a little bit easier to find ways to get the stuff that can keep you at home and ultimately keep costs down, but it's an out-of-pocket cost right now.
I think that's really hard for a lot of people too, though, right? Because then we're adding one more thing to their plate that they have to figure out. And a lot of times it's like, okay, not only are they figuring out how to take care of this person and navigating all of the issues and the appointments and the medications, but now we're also having them have to figure out how to get equipment that should just be available through insurance.
Yeah. Yeah, they do, but it's not, so they have to.
Yeah, yeah.
It's less expensive and easier to figure out at that point of the game than to figure out how to get your spouse into an assisted living because you can't do it anymore because that's also not covered. And one partner doesn't want to go to the community and one partner needs to go to the community. So, or if they both go, it's just extremely expensive to do that unless they go to the Medi-Cal skilled cares, which nobody wants to be in there.
Yeah,
Nobody wants to be
yeah,
in there.
yeah.
Yeah, so it's tricky. Every area in the United States is different, and there's different resources. We do a lot of equipment recycling for Parkinson's and ALS, but we take stuff out of that and donate it back out to people without those diagnoses too. But a lot of it is the smaller items, and then it's buying used of the bigger items that can save the money. But there's not a program and there's not a big enough space to really do a bona fide like warehouse full of used equipment because there's so much out there that you clean and donate back out. It is a second business in mind of 1C3 type thing that
Hmm.
I think about a lot because there's definitely an ability to do it. But we just do it free as part of our company for the small items like walkers and canes and transport chairs. We have a lot of those that we recycle back out to people. And then our bigger ticket stuff we sell at a discount once we've rented it in our fleet for a little while. So that helps.
Yeah. Yeah, that is really nice. I know there's a lot of lending closets and like Catholic charities and a lot of like other resources, community organizations that will have supply closets where people can go and help themselves as needed in various communities. And so you do have to look for them sometimes, but they're definitely there. It's just a matter of having to look for them. I do want to go back to earlier you talked about how equipment, specifically the assistive devices like canes, walkers, wheelchairs, rollators, things like that. Rollators are never covered usually in my experience, but all those other stuff, they only get covered every 5 years under Medicare. And one of our recommendations in the hospital oftentimes is, a cane is what, $10 at the store, right? And it's like, if you think you're going to need a walker within the next 5 years, go buy that cane yourself and let's wait and get you a walker through insurance, right? If someone has something progressive and we know it might not last 5 years, then it's more of like, okay, let's wait, you might want to buy a cane and a walker out of pocket, but let's get you that wheelchair. And so I think understanding almost, I mean, it's terrible that we have to do that, but we're almost trying to like figure out how to work the system, right? So that they can
Yeah.
get access to the stuff that's more expensive and afford the things that are less expensive.
Yes, yeah, absolutely. Now you can get, even if it's not 5 years, you can get the next item, but it requires a change in condition, paperwork, documentation, and more effort. And if it's going to be close, because a lot of people will get a walker and a wheelchair or need that transferring out of the hospital from a hip or something, then yeah, you buy that walker and get the wheelchair. If they're in a scenario where they may need to be in a wheelchair longer throughout the day and want to try to qualify for a higher end one and really do the documentation around that, then don't get that transport chair that they might offer you for hospital discharge. Like just buy that and fight for your K4 or K5 chair, the lightweight or the ultra lightweight. So absolutely. And same when you're at the wheelchair versus power chair line. If you're going to potentially qualify in a short time span, then go for that bigger ticket item.
Yeah, absolutely. We usually see it with kind of what you were saying earlier of like, oh, they can get around using a cane in the home, but might need a walker for the community, right? Because of uneven surfaces and sidewalks and things like that. And so that's usually like the tricky part that we'll see. And it's like they don't want to use a walker in their home, or they can't use a walker in their home. It's like, okay, well, go buy the cane, we'll get you the walker, right? So I think just trying to be mindful as a provider too, of trying to be like, what can we get them so that they don't fall and that they can still continue to live their life?
Yep, and finding out what other agencies are involved. So some home health companies are kind of rolling the cost of the one of those basic items, like maybe they'll get that walker, but then they'll give them the cane, or vice versa. I've seen that lately too, where they're just putting some equipment into their stock hold and giving it out. I don't think they're charging for that equipment. I think they're just considering it part of onboarding cost of the patient. And then also for people to understand in hospice, if someone goes on hospice, first, it doesn't mean that that's the end of the line. You can go on hospice and come off of hospice. It's a great resource to use probably earlier than a lot of people think. They do have to get it prescribed and meet the criteria, but it's a great resource to use. And then the hospice covers all of the equipment they may need, basic equipment, but they're not having to do all this qualifying criteria. They can give them oxygen, a bed, and a air mattress without having a decubitus already. So it's another thing to consider, is what are the different care agencies that I'm going to use or could potentially use that can help me meet my equipment needs as well.
Yeah, I think that's really important. We do see a lot of, like if someone's transitioning to hospice, it's immediate, okay, you're getting all the equipment that you need. Even if they don't necessarily need all of the equipment, it's usually just more of like a point of order of like, okay, transitioning to hospice, they get a bed, like you said, a bed, a mattress. If they need oxygen, they get that. Usually they'll end up getting other equipment too, like a lift if they need one, or a wheelchair if they need one.
I've seen hospice companies up-leveling the kind of equipment they have in the last couple of years. At least in San Diego, they've been up-leveling with full electric beds and even really nice wheelchairs and stuff. So it depends on the service provider in the area, but they've been doing a better job. So, with that, not everyone's even close to being able to qualify for hospice, but if you are, if there's something going on, I would say don't be afraid to use it. It's designed more how I think care at home should be, even if you're not hospice qualified. And it gives a little bit of respite care to the families because you have more layers of check-ins and home health or nursing people coming over to help a little. And I know hospice is expensive to the system, but some version that's closer to that than what they do now for regular equipment approval and care at home would be so tremendous for our healthcare system and give people the support they need. But for now, accessing it, at least in that scenario, is something people can do.
Yeah, definitely. What do you think, based on your experience, like what are some high level changes that would improve access to some of the equipment for people? Changes to like the system?
Yeah, I mean, there are so many.
Yeah, like I could share mine, right? I wish we didn't have to qualify people for equipment. I wish we could use our judgment, our professional judgment, and say, hey, this person's at a risk for falls. They do better with a walker. We're just going to get them a walker. Done. End of story.
Yeah. That was an interesting way to do it. Potentially, what if the system is qualifying us as providers every so often, like auditing some of our cases every couple years, seeing the true need there, the outcome was good, so then you get a sign off again for another 2 years, 3 years, for whatever, that your word is gold to prescribe whatever equipment they need. And they're just kind of like validating the ethics and the outcome of the provider versus analyzing every single patient case.
I think it's moving a little bit towards that way. So for those who might not be aware, generally the only people who can prescribe equipment are physicians, and they have to sign off on a referral. And generally they're getting these recommendations from therapy, whether it's OT or PT. And then they have to go through that process, and it is a process. And so in Illinois, this session, we actually just passed a bill where PT and OT can now prescribe equipment. And
That
so
makes more sense, right?
yeah.
You know the equipment better and you know the case better. Doctors are very off in, their specialty and their thing. And I often find they don't actually understand the equipment at all, and they're not in the nitty-gritty of the client use case.
Correct, exactly. And then this just kind of also eliminates the whole middleman process, right? It's like, if we're the ones making the recommendations, why are we not the ones making the referrals? Like, it just doesn't really make sense. And it's almost as if we are being supervised or have oversight from physicians, which is not a thing, right? And so it's one of those of like, we are independent practitioners. We should have the authority to do this if we're the ones making the recommendations. I mean, that's like an eye doctor recommending glasses and then the physician having to sign off on it, right? Like, it just doesn't make sense.
Yeah, yeah, that's awesome. That's great, and it will streamline the process and help people get things quicker. And it may for the system, I don't know if they're taking out the additional OTPT assessment that's usually required, or I guess it's just one, but it might be one less billable code they have to cover too.
Yeah, we'll see. Well, it just passed the session, so we'll have to see kind of how it goes through the system and how they develop a system around it and what it actually looks like when it trickles down and all of that. But I thought it was a move in the good direction to at least try and streamline some of this and see how it plays out.
Yeah.
But I think with that comes a great deal of responsibility to understand how this works too, right? Like, what's covered, what's not covered, which plans cover it, which plans don't cover it. So I do think we need more education on that front from on the therapy side, because we're really good at making recommendations. But unless you've worked directly in equipment ordering and supply, you have no idea how much of it is actually covered and how much is not, and what those requirements and qualifications are.
Yeah, I think it'd be working with your different medical equipment providers, the ones that are contracted. There'll be a handful, because not everyone's contracted with everybody, but they can do those in-services and those educational pieces about the criteria for each payer and what's covered by each payer.
Yeah, absolutely. Can you talk to me a little bit about, so you mentioned contracting, and so are these home medical suppliers, companies, clinics, usually contracted with like a medical equipment company? How does that work?
They're usually contracted or enrolled with the payer sources. So Medicare, Blue Shield, Aetna's, they have their contracts in place for the insurances, and not all places accept all insurances. So the client or the referring provider needs to call the insurance that they have to find out who the contracted DMEs are. Okay. And then the DME can buy kind of from, we can buy, as far as from medical equipment vendors, we choose then who we want to buy equipment from. So the payer doesn't dictate what products we carry or what we distribute. They just dictate how much we're paid for the category, and then we choose the manufacturer that we distribute from. And that was a big distinguisher with my company when we did bill insurance back before competitive bid, was always carrying the higher quality equipment. And if there was a discrepancy in the cost for that equipment from what the payer paid, then we would give the patient the opportunity to just pay the difference. Not every place does that, but that's called an ABN. That every place has the ability to do. It's just a little extra paperwork. So sometimes, especially if they're a big national just cranking through them, they may not offer that or want someone to ask for that because it's a little bit more work. But definitely smaller providers should probably be open to giving an ABN and getting them what they actually want.
Yeah. That sounds very similar to how private therapy clinics operate as well. So we're usually contracted with different insurance providers, payer sources, and then we usually have to provide an ABN if we have a different cost versus what insurance pays. We can't do an ABN for Medicare within our services. We have to adopt whatever Medicare will pay for our services, but for commercial payers and like other insurances, we can have an ABN on file that the patient signs and will say like, hey, if in case insurance doesn't pay the full amount, like you'll be responsible for the difference. And that is helpful in some cases.
Too. Yeah, that
Yeah.
varies by for equipment companies. Some will be enrolled in a way where they've signed up to accept the Medicare level and they are not allowed to do an ABN. And
Hmm.
then others have enrolled non-assigned and they can accept the ABN. So it does depend on how the provider contracted with Medicare.
Yeah. Yeah. I think, yeah, there's a lot of parallels here. And I think that's really nice to know or understand kind of how that works. Because I think for us on the complete other side where we're just making the recommendations, I think we don't really, we think it's just a wide network of medical supply stores. And we're like, go get this, you know? And we don't really think about all of the stuff that goes into it.
Yeah. Yeah, and I would recommend people to go in to a medical supply store, one that's more like Harmony that has a retail type of supply store to really, and if they're not in an area where they can, then go onto our website and peruse some of the product knowledge pages and to really see what's possible. Because I started this business because I was working for my mom right out of college. She had a health crisis. It was a family business, and I went back to work with her because I never wanted to do DME. I cleaned and delivered wheelchairs all through high school. I was like, I'm done. I didn't get to do the grown up work at that stage. And then she had this crisis, a health crisis and an embezzlement at the same time. That's how she found out she was
Oh,
having an embezzlement. And I went back up there and was doing everything she was doing, just kind of thrown into it. And I was doing home assessments and measuring people's bathrooms and doing all this really amazing equipment. And it was for Regional Center, who paid for anything really. It paid for so much. That's a group for developmentally disabled children. And I said, why don't you show this stuff to the public? Like, why don't you show your Medicare recipients this? Why don't you have it in a showroom? Because she was an insurance facing kind of warehouse based business like most DMEs are. And she said, oh, because Medicare doesn't cover it, so nobody will pay for it. And I said, I don't think so. I said, I think people want to know about this. They want to know about roll-in showers and bath lifts and car lifts and ceiling lifts and these like really cool high-low adjustable beds. And she's like, no, this is not covered, so no one will pay. I said, okay, well, we're going to challenge that when we get through this mess. And we got through that mess, and then I came down to San Diego where that was in Redding. It's a smaller town, but I live in San Diego, and there's more people with disposable income. There's also a larger population. But we tried it. I did it at the Del Mar Fair as my litmus test. And we sold out of like all our nicest stuff, and people were very interested in it, getting a home assessment set up. And then so we did another little shop and a little bit bigger. And today we have two nearly 5,000 square foot showrooms full of the latest and greatest. And they're popping up all over America. People want to see and they want to know, and they will pay for what they need when they see there's a better solution. They figure it out. And so that's how
mhm.
this business is born. And that's what I recommend so many people to do because they don't realize what's out there. And there's really more than ever because of the baby boomers and the silver tsunami. So a lot of R&D and product manufacturers have been putting effort towards this industry for the first time that I've ever seen. The first time we're having so many new chairs. I get a new chair intro like every month between the lithium ion and carbon fiber. I just got my first self-driving power chair in the store yesterday. You can
Oh my
program
gosh.
all these spots in your house, your kitchen, your bath, and then you just say, "Take me to my bathroom," and it will drive you without crashing into anything.
Wow.
So yeah, so there's a wave of people who are going to need these things, and manufacturers know that, so they're finally looking towards our industry with some resources and developing stuff. So I'd say yeah, go and play somewhere, go check out a store and
Yeah.
go see what's possible. Because I didn't believe ever in just looking through the lens of insurance because it's never been the optimal. It's never been like what's truly the best for people, but it is some support. It's nice to have, but they don't go far enough.
Yeah. Yeah. Do you ever partner with local like OT practitioners or PTs to figure out like what the right equipment would be for the patients or the families?
Yeah, yeah, all the time. So we have OTs and PTs that call us out a lot to do the home assessment for the bars and the ramps and that sort of thing. They're generally listening for the equipment and they'll also recommend us for that, especially if they want something that's not covered or they don't quite meet the criteria. And then when it comes to the regional center, who we still are a vendor for, they're a third party payer. Then there's a lot of collaboration there too with the joint home assessments because there's back into the documentation world, the OT and us, we're kind of leading the charge on the recommendations in those settings, and OT's documenting all of the physical reasons and tying it back to conditions and everything that they want to see as to why they need it.
Yeah, truly a collaborative approach. That's great. Great to
Yeah.
see. I think earlier you mentioned something about why some things are not covered specific to like I forget the term you used. Was it like a secondary use or something like that?
Yeah, for secondary use. Secondary activities are, shopping and doctor visits and going somewhere fun. All of those are non-critical or non-part of ADLs, and not so much of the criteria is around the ADLs and just getting those done. And that's really all that insurance cares about is can you perform your dressing, bathing, feeding, your activities of daily living.
But in that same regard, they don't cover bathroom equipment, which is literally ADLs.
Yes, right? Literally. I know. Yeah.
So that's where like I never understood like the rationale behind it. I know like, I don't know if this is a rumor, but like our understanding was like if someone else can use it, then it's not personal and so therefore it's not covered. And I'm like, if it's in the bathroom, who's removing the chair every single time? Like, I think that that's a little ridiculous to think of it that way. Or the toilet riser, who's going to remove it every single time someone needs to use it if there's a shared bathroom? And
Yeah.
I don't know if that's true, but I feel like that if it is, that is a ridiculous way of looking at it.
Yeah. They used the 3-in-1 commode was the answer, and it was covered like all the time before. And they clamped down on that and made it really for that bedside care. But it was called the 3-in-1 commode. It was developed because it was supposed to be the bathroom solution. And it's not like the only bathroom solution. But that's kind of how insurance was originally framed out, was that's going to meet their toilet riser need. It's going to meet their shower chair need. It's going to meet their bedside need. And so they use that. But now they don't even use that. Like now it's even so difficult to qualify for a commode, and they didn't put in any other products to accommodate. They're upside down in the bathroom setting.
Yeah.
It's crazy.
Well, and the 3-in-1 is assuming that there's a second person available to keep moving it.
They're moving it around. Yeah. And it's
Yeah.
really not designed. They are not great shower chairs, and they rust out with a bunch of water in them. And yeah, there's no.
Yeah, yeah. We do have, at least my experience is we haven't had pushback with recommending bedside commodes for overnight use for higher fall risk patients who have a urinary condition. And so we will use that to our benefit as much as we can a lot of times. And so I haven't had pushback on that. And we have seen it covered for quite a few people that way. So could be an
Yeah.
option potentially if you haven't ran into that yet. But yeah, just have to get creative with it.
No, that's absolutely what they approve it for now, is for bedside as opposed to like bathroom use. It's what reason do they need it bedside? And that's a great reason. So
Yeah.
so that
Yeah.
works. Yeah.
Yeah, absolutely. Well, I think I learned quite a bit and you validated a lot of what I thought I understood about this too. So thank you for doing that. If there's something that you want, we have a wide range of listeners here from providers like therapy practitioners to families and adult children who are navigating caregiving for their parents and older adults who might be listening just for their own knowledge. What is one like takeaway that you think that they should all learn or understand from this conversation?
I think the idea of educating and getting a little bit of a plan in place around equipment. So to go to a store, to look online, to reach out to an educated partner like yourself, to somebody who could say, these are the items that could really make your life better. Because there's the items I think we briefly mentioned, like the lift chair, that are not mentioned in any coverage criteria because they're not covered at all. But to understand what an optimal home setup can look like, from equipment to home mods to all of it. So you can start to think around a plan for being able to access those items and know they exist and kind of understand when you could call them in to make your life easier. And I would say think sooner than later, or maybe make those decisions before your instinct might say, oh, that we absolutely must have to now. There's a lot of psychological resistance to getting equipment, and it's not until like the fall happens or the inability to transfer happens. But I would recommend exploring that equipment and trying it out before the absolute must-have happens, to really see that it can be a game changer in the comfort, confidence, and care potential in someone's life.
I think that is fantastic advice, and we will definitely 100% back you on that, especially as an OT practitioner, trying to help people stay at home as long as they possibly can or want to. Erica, thank you so much for joining me today.
Thank you, Pooja. This was wonderful. Thanks for having me.
Absolutely. Thank you for listening to the Aging Together podcast. If today's conversation helped you, please follow the show, share it with a friend, or leave a quick rating or review. Your support keeps this podcast free, ad light, and growing. Until next time, let's keep learning and aging together. Take care.